we'll conclude the hepatitis portion of this lecture with viral hepatitis, which is probably the most commonly tested hepatitis on here. And so regardless of whether it's Hep A, B, C, D, or E, these all hold true. So these are all inflammation of the liver due to some sort of viral infection. It's usually going to be Hep A to E, like I mentioned. You can get EBV, CMV causing it. They're not going to test you on that though, really. You can have it acute or chronic. And so let's talk about how this can present. This can be asymptomatic, but if it does present, it's going to give you your classic hepatitis symptoms that we've been talking about. You can get fever, you can have jaundice, nausea or vomiting, you can have dark urine, you could have right upper quadrant pain. And on labs, you can either have a mild transaminitis, you can also have significant transaminitis, an acute infection. So the presentation is pretty variable. It's not going to trip you up though. They're going to give you your classic hepatitis symptoms if they're in acute hepatitis. If it's really bad, if it's like a severe acute hepatitis, you could be going into liver failure. And so you can have a high PT-INR, decreased albumin, and all that stuff, in addition to all the excessive transaminitis and all that. And another laboratory finding, and I'll go into detail as we go through each of the different types of hepatitis, you can get positive serology markers. And that's usually how they end up testing these anyway. So regardless of the hepatitis, you could get a macrovesicular steatosis as well as Councilman bodies. We saw the macrovesicular steatosis when we talked about both the alcoholic liver disease and non-alcoholic. And that was just when you have this big fat vesicle that's kind of pushing everything else out of the way. And I have a few of them circled on the screen here. And again, you see these in more older conditions like fatty liver disease, alcoholic liver disease, and you can see it here as well. And my mnemonic for that was that these conditions generally happen at an older age, like when you're more of a macro person. So you're going to think of that because later on when I talk about Rye syndrome, a childhood disorder, that causes microvesicular steatosis. Viral hepatitis can also cause Councilman bodies, and these are eosinophilic globules of apoptotic liver fragments. So what does that even mean? That just means that your liver cell was infected by hepatitis and it went through apoptosis, which, remember, that's the controlled cellular suicide, where the liver cell knows that it's infected and it performs the steps in a correct manner to shut off, essentially, in an organized manner. And you can see that right here, this pink stained cell that's kind of gradually dying here. That's a Councilman body. And you'll see this mostly tested in all the viral hepatitis, but you can see it in yellow fever as well. And so some complications we have to keep in mind when we're talking about viral hepatitis is that some of the viral hepatitis, especially hepatitis B and C, can cause a chronic infection. And if you have a chronic infection, that can lead to liver cirrhosis, which can in turn lead to hepatocellular carcinoma. And of course, death is a complication not only of this pathway where you get HCC and die from hepatocellular carcinoma, but even in acute hepatitis, if you have really bad acute hepatitis, you can go into liver failure and die from that as well. And treatment's going to depend on which hepatitis we're dealing with. So as I go through each of the 5 main hepatitis, Hep A, B, C, D, and E, we'll talk about how the treatment may vary. So we're going to go in alphabetical order, and we'll start with Hep A. And so this is an RNA picornavirus. It's transmitted fecal orally. What we'll find is that Hep A and E, which are kind of our front and our back of our alphabetical Hep A and E, those are both going to be our fecal oral transmission. So a lot of people remember that because it's the front and the back of our hepatitis, just like this fecal oral is kind of the front and back of our GI tract. So the risk factors for hepatitis A, you often see it on tests in travelers, somebody who traveled to an endemic country. You can also see this in daycare. And another thing they love is this association with shellfish consumption. And so this will present differently depending on whether you're an adult or a child. In adults, you're going to notice the symptoms. It's going to be fever, malaise, nausea, vomiting, jaundice, right upper quadrant, abdominal pain. So all those classic hepatitis symptoms that we mentioned, you're going to see it very, very pronounced. It'll last about 1 to 2 months. In children, on the other hand, oftentimes they are asymptomatic. So to diagnose this, you can use serology testing. And so you can use the anti-hepatitis A virus IgM, which will detect an active hepatitis infection. You can also use the anti-hepatitis A IgG, which is a protective antibody, and that'll tell you whether or not the person either had hepatitis A in the past or was vaccinated. Just want to point out here, you're going to see a lot of these dash. That all that means is that your body has produced an antibody to whatever comes next on that NIT. So in this case, all this is telling us is that our body has produced an antibody to the hepatitis A virus. And in this case, you can have an IgM antibody and we can have IgG antibodies. This will be important when we talk about hepatitis B because you're going to have a lot of different serology markers. And so it's good to get this framework in mind now before we get to Hep B. And so I have a pictorial representation to make sure we understand the difference between IgM and IgG antibodies, because again, this will be important regardless of whether we talk about Hep A or another different type of hepatitis. So let's say this is the virus that ended up somehow getting into your cell. Early on in an infection, IgM antibodies are going to bind to whatever is causing this damage. And so let's say hepatitis A is in this hepatocyte. So the purple thing will be our hepatocyte. What'll happen is that initially our body has these IgMs. And so why does this even happen? Why do you have IgM first and then IgG later? Well, IgM, as you can see, it has 5 different arms here, and each of these arms has 2 binding sites. So this thing here can bind 10 different antigens if it wants to. And so it's kind of useful early on in an infection because it can give you, at least it gives you more opportunities to bind to something. The issue with the IgM antibody is that it's not as specific. Like these antigens, sure, you have 10 binding sites, but they're not perfectly in tune for every hepatitis A virus, for example. It'll take time for your body to mount an immune response and to create an antibody that's specific to that viral subtype. So either way, my tangent there was just to say that early on in infection, we have this IgMs, which can bind to either the virus directly, or usually it's going to bind to some sort of antigen that's presented on the surface of a cell. And so if you ever see IgM, as I just talked about, you're only going to see this early on in an infection. So if you ever see an IgM antibody, that's telling you that there's some sort of active infection going on right now. Over time, though, IgG is going to start predominating. So over time, we're going to have our lymph nodes and other cells can produce antibodies, and these are more specific to whatever antigen was presented initially. And these are going to be IgG antibodies. So over time, either whether it might be a late infection, you'll see this transition from IgM antibodies to IgG, or you'll still see these IgG. Let's say that hepatocyte or that virus has been killed off and you don't have an infection anymore. You'll still see these IgG antibodies. So this anti-HAV IgG right here, you'll still see this in our bloodstream if we measure it. And that could be either due to a resolved infection in the past or because of a vaccination that kind of produced the same immune response in the past. Hepatitis A is a self-limiting disease. So as long as you make sure that they are adequately hydrated and you keep them symptomatically managed, then the disease should go away on its own within 1 to 2 months. Now let's move on to hepatitis B. This is caused by a DNA hepatinovirus. And the classic transmission patterns you're going to see are all the Bs. You can get it through birth, you can get it through blood products, or you can occasionally get it through bodily fluids, so through sexual activity. And this will present in adults. This will usually be a resolving infection. It'll be those same acute hepatitis symptoms, and then they'll go away. In neonates, though, it's more often to be chronic, and it's usually asymptomatic, excuse me. And as you can see here, one of the risk factors for hepatitis B is birth. So you can transmit this from mother to child, and that's why we have that's why we check for hepatitis B as part of the prenatal screening, and we make sure to vaccinate early if we can. So on laboratory findings, you're gonna find classic hepatitis B serology markers, and I list some here. So let's move on from serology and talk about histology. For hepatitis B, you get this ground glass appearance on biopsy, and you can see what that looks like here. It looks like frosted glass, which I can see. You can see it throughout, this frosted glass appearance. And that's indicative of Hep B. And treatment of Hep B, I talked about it when I talked about the risk factors, about how birth is a big risk factor. So a good way to limit Hep B is to make sure that everybody has their correct vaccinations. And the treatment oftentimes in adults is just symptomatic management, because in adults, it rarely progresses to chronic disease. That's more of something that happens if you had it in childhood. But you can give some antivirals. There's tenofovir and entecavir as potential treatment options. Some complications is chronic Hep B, which happens more often in neonates, but can happen in adults. And that would lead to liver cirrhosis. And as we've seen before, anything that can cause liver cirrhosis, anything with chronic inflammation, can lead to cancer, in this case, hepatocellular carcinoma. Another complication I want to mention, and I'll talk about this when I discuss hepatitis D, is that hepatitis D can only infect you if you already have hepatitis B infection. So people with Hep B are at risk for either an hepatitis D co-infection or superinfection. And there are several other complications of hepatitis B. The most important for you to recognize on this is this one disease called polyarteritis nodosa. I don't have a slide on it, but this is a vasculitis that they do test sometimes in conjunction with hepatitis B. I'll go over all the other, this anemia, the kidney problems. I kind of mentioned that when I talk about hepatitis C, because there's so many different infections, and it's through the similar mechanism. So this is a good time to segue into hepatitis C. So hepatitis C is an RNA flavivirus, and similar to hepatitis B, it's produced through some of those same mechanisms that we talked about: blood transmission, so like transfusions, and we talked about bodily contact. So this will present, it could be asymptomatic, and that's generally how it is presenting, just as an asymptomatic positive screen. So you're going to diagnose this with, again, we're going to use antibodies. So you're going to diagnose it with the antibodies to hepatitis C virus, either their IgM or IgG. And once you've done this, because it's an RNA virus, you can actually just test their RNA load to differentiate whether or not the hepatitis C virus is ongoing or if it's recovered. There are several hepatitis C treatments. I've never taken too much stock into these, so I apologize if you were hoping that this section would be the one time you learn all these different names. There are a ton of different protease inhibitors that you can learn. There's the NS3A and 4A protease inhibitors like glecaprevir, grazoprevir, and cimeprevir. You can have the NS5A inhibitors like decladasvir, ledipasvir, velpatasvir. And finally, you can have the NS5B inhibitors like sofosbuvir and dasabuvir. Let me think about how I've seen these tested. I have definitely seen them give you the medication, and then they ask you what is the mechanism of action. So they'll give you like sofosbuvir, and they'll say what is the mechanism, and they'll have NS3A, NS5A, NS5B. So just remember that if you ever see a B, like the buvirs are all your NS5B. It's a little harder to determine these ones here. The asvirs are your 5As, and then the previrs are your 3A and 4A. So however you want to memorize that, I apologize. I always remember this one, the B, as our NS5B. So they do occasionally test that though. Ribavirin can also be used, as well as pegylated interferon alpha. So instead of focusing on that, I did want to focus a little bit about the complications. So we've already seen that anytime you can get a chronic hepatitis infection, that can lead to cirrhosis, and which can lead to hepatocellular carcinoma and death. There are several different complications that they sometimes test. They have mixed cryoglobulinemia, lichen planus, and porphyria cutanea tarda, as well as all of these different types of complications. And usually when you're studying for Hep C, you'll see all these complications and you'll kind of gloss it over because there's just so much that you have to memorize for such a low yield concept. So what I want to do is I want to put this in a framework that you don't have to memorize all this stuff. It'll just come naturally to you if you ever get tested on it. So I'm going to start by talking about mixed cryoglobulinemia. So cryoglobulins are immunoglobulins that end up basically forming, like they precipitate. So they kind of form stones, let's say, at colder temperatures. So what happens here is that you're going to get an hepatitis C infection that'll activate your B cells to produce a ton of immunoglobulins. And when these immunoglobulins reach areas that are kind of cold, like your fingers, your toes, your arms, and legs, all those immunoglobulins will start forming these precipitates, these stone-like things. And you're going to get these things called purpura in cold-sensitive areas, as you can see here on this screen. So let me show that in pictorial form. Let's say you have an active Hep C infection. Your B cell is going to secrete a ton of either IgM or IgG antibodies, depending on where you're at regarding timing. And your red blood cells will try to come through, and they want to use this blood vessel. The problem is that all these immunoglobulins, especially when they reach cold sensitive areas, they're going to precipitate and form a stone and kind of form a blockage to those red blood cells. And so you're going to get these like mini clot-like things here. And that's how you see that purpura that we discussed earlier. I'm going to use that same framework to talk about a lot of the other symptoms, because most of the other symptoms that we find are pretty much just related to that massive immunoglobulin release in the first place. So again, let's say we have our virus and our B cell produces a ton of antibodies. All those antibodies, some of them might reach the kidneys and overwhelm the kidneys, and your kidneys can get damaged, and you can get membranous glomerular nephropathy or membranoproliferative glomerular nephropathy. What about the complication of ITP or autoimmune hemolytic anemia? So ITP is just an autoimmune destruction of your platelets, and autoimmune hemolytic anemia is just an autoimmune destruction of your red blood cells. So again, if we have our virus and it causes our B cells to produce a ton of immunoglobulins, sometimes those immunoglobulins can actually interact with our own cells too, especially early on when it's kind of nonspecific. And that can damage our platelets or our red blood cells and cause either of these conditions. Now let's talk about non-Hodgkin's B cell lymphoma. So again, if you have your hepatitis C virus and your B cells producing all those immunoglobulins, if your B cells are working too hard and they start forming mutations, you can actually get a B cell lymphoma in the process. This is the gamma gap is something that I've seen in UWorld a few times now on both step 1. I remember seeing it on step 1 initially, but I saw it more for step 2 study resources. The gamma gap is your total protein level minus your albumin level. And so what this will do is, remember how albumin usually makes up at least half of our plasma proteins. So this gamma gap, what it does is it'll measure the proteins in your body that are not albumin. And if your gamma gap, so if the amount of proteins that are not albumin ever exceeds 4.0, then you should consider some other mechanism that's producing a ton of proteins. And usually the proteins that are getting produced are excess immunoglobulins. So you'll see it in hepatitis B or hepatitis C infection, because we've just discussed how oftentimes in either of those conditions, you get a ton of immunoglobulins. You get a lot of antibodies that are released into your bloodstream. You might also see it in multiple myeloma or Waldenström's macroglobulinemia. And those are conditions where you produce too many immunoglobulins due to some sort of cancer. Before we move on from Hep C complications, I do want to talk about a skin condition called lichen planus. And so lichen planus is an immune-mediated rash with a strong association with hepatitis C. How this is commonly recognized in study resources, they like to give this mnemonic of the 6 Ps. So the lichen planus rash will usually be purple. It'll usually be very pruritic or itchy. It'll be polygonal, which is has many sharp edges. I think of like the Pokemon Polygon. And you can either have, I'm going to put both of these up. You can either have papules, plaques, or both. And all those mean a papule is a raised lesion that's less than a centimeter, and a plaque is a raised lesion greater than a centimeter. So you're going to have some sort of raised lesion. And either of those raised lesions will be planar, which means that if you get to the top of that skin lesion, it'll be flat. So here are a few different pictures of lichen planus. Well, actually on the left, we have lichen planus, which we just talked about. And on the right is a specific subtype of lichen planus. This is Wickham striae, which are visible lines that you can see within the lichen planus raised lesions, especially within the oral mucosa here. So all these white lines that you see, that's called Wickham striae. You technically can see them sometimes on actual skin, but I've never seen it tested in the skin. I've always seen Wickham striae in the setting of oral mucosa, oral lichen planus, essentially. Let's finish it off. I guarantee you Hep B and C were the most high yield, and that's why I spent so much time with it. We're going to now talk about hepatitis D. So hepatitis D is caused by an RNA delta virus, and it has the same transmissible risk factors as hepatitis B, so our 3 Bs of birth, blood products, and bodily fluids. But in contrast to hepatitis B, hepatitis D actually needs an active HBV infection in order to enter the hepatocytes. And so this will present as somebody who already had hepatitis B and now presents with a super infection. That's concerning for a new hepatitis D infection. You diagnose this, as we've seen with most of these, you diagnose this with an antibody to hepatitis D virus, either the IgM or the IgG. And you can, again, because it's an RNA virus like Hep C, you can actually test their hepatitis D virus RNA load to see if it's a resolved infection or if it's an infection that's continuing. You can treat this with interferon alpha. And like I said, the complication you need to be aware of is that super infection. They're really not going to, or co-infection. They're not going to emphasize this too much. It's really just going to be somebody who has known hepatitis B, and then they all of a sudden have a really, really, really severe infection. So they might have had chronic Hep B, let's say, and all of a sudden they have this extreme infection. That's when you need to consider hepatitis D as the culprit. And hepatitis E is our last hepatitis that I want to talk about. This is caused by the RNA hepivirus. This is fecal oral transmitted. And remember what I said before was that Hep A and E are the front and the back end of our hepatitis viruses. And that should remind you that their transmissibility is also from the front and the back end of our GI tract. So that's why you get this fecal oral transmission. Whereas Hep B, C, and D have more of that either birth, bodily fluid, or blood product as their transmission usually. So this can be through contaminated water, and it presents the same way as other hepatitis infections. But the one caveat, and this is really the only way they test this, maybe not the only way, they'll either test it by saying somebody has Hep E and they'll ask you about the transmission, or they'll test it more commonly as a pregnant woman who has fulminant liver failure. And so you can remember the E for the E in pregnant, or some people like to remember expectant mothers, which is, another term for pregnant. The E for hepatitis E is the same as the E in expectant mothers. And so if you ever see hepatitis causing fulminant liver failure in somebody who's pregnant, strongly, strongly, strongly consider hepatitis E. And it is a self-limiting disease. So that's the only thing you really have to know about hepatitis E. And again, I've put together a study aid for you because we talked about a lot of different things there. And so here's your nice study aid. And remember, I also made a study aid specific to the hepatitis B serology markers because that is, again, one of the more high yield subcategories of this entire section. Thanks for watching. I hope you enjoyed the video. Please like, comment, and subscribe for more content.